Hi, I'm Bisma, and you're listening to The Other C Word, a podcast about all things cancer from a stage 4 breast cancer warrior. We cover health and
So I want to
wellness,
start
mind,
by
body, and
saying
soul.
no
Plan to
imaging
leave
is
each
perfect.
episode
And
with
I
hopefully
think
some
that's
new
hard for
insights
people
and
to hear because
inspiration.
I think we
Let's get
all
into
want
this
one
week's
special
episode.
test, right?
Hey everyone, welcome back. Today we have a very special guest, Dr. Sonya Bhole, with us. Dr. Bhole is an associate professor of radiology and also a fellowship trained breast radiologist. So we're super excited to have her on the podcast today. Welcome.
Thank you so much for having me. I'm so excited for this conversation.
Thank you. So why don't we start with a little bit, maybe your background and a little bit of information of like what does a breast radiologist actually do?
Yeah, sure. I think it's a great question because I can tell you it wasn't until, I got into my 30s and 40s that my friends even knew what I did, because I think it becomes more and more relevant as you've talked about so much on your platform and sharing your story as we get older. So I am a breast radiologist. So what does that mean? Maybe we should start by saying what a radiologist is. So I went to medical school for 4 years after undergraduate. And then I did a year of generalized medicine. And then I did 4 years of radiology residency. And then I did an extra year to subspecialize in breast imaging. So a radiologist is the doctor that reads the imaging. And a lot of people don't know about us because we really work behind the scenes. So when you come into the emergency room and you have trauma, or you have a belly ache or something's happening, you get the images and you're really talking to the team in the emergency room. But we're the people behind the scenes that are reading that, directing the surgeons where to go, and kind of helping with your care. But a lot of times we hide. And so I think what's really nice about a breast radiologist or the breast radiology world is that we actually are patient facing. We're the ones that are reading your mammograms, but we talk to you when something's happening. If you're feeling something, we come and scan. We're the ones doing the biopsies, placing the clips there for the surgeons, and then queuing you up to go to surgery. But not only are we doing that, we get to help you with your surveillance afterwards. So we're really a part of every woman's journey, whether it be their annual mammogram, their diagnoses, or their surveillance afterwards. We really get to hold hands and be there the whole way, which is what I love about being a breast radiologist.
That's awesome. That's such a great explanation. And I agree. I think from my past experience, like the radiologist is usually behind the scenes, except when I've noticed in breast care, I actually get to speak to my radiologist and they'll actually come in and talk with me. So I totally agree. It is like a more, person facing role than your typical radiologist is.
Yeah.
Okay. So actually what Dr. Pole and I did over our social medias a couple weeks ago is that we did a Q&A. And so we wanted to get in your questions on what specific things you're wondering about related to breast radiology. So I think what I'll do is I will get into the questions. I've grouped them by category. Let's start with mammograms. So one of the questions is, are mammograms sufficient or should ultrasounds be performed too? What is the most clear and accurate scan for detecting breast cancer?
Yeah, it's a great question. I guess before we even get into this, I just want to thank all the followers for the questions, because this is what I'm passionate about. I know you're passionate about. That's what drew me to you, is that we really need to make this an everyday conversation. I think people are so scared to talk about these things. And when it becomes a daily conversation like it is in my world and your world, I think we can just empower so many women and just change so many lives. So I just really appreciate people putting themselves out there and asking those questions that might be uncomfortable. So I want to start by saying, no imaging is perfect. And I think that's hard for people to hear, because I think we all want one special test, right? We hear mammograms are bad with dense breast tissue. We hear MRIs lead to a lot of biopsies. We hear PET scans only show certain things. Now there's whole body scans, which I think we're going to get into. So I think people want to say, me to say, or radiologists say, or doctors to say, this is the perfect imaging test for this. But that doesn't really exist. And I wish it did, but it doesn't. And so I think the best test, the gold standard for breast imaging, is really mammography. It is the test that we know has been proven to save lives over years and years and decades of research. Since starting mammography, the death rate from women with breast cancer has decreased by 30 to 40% from just screening mammography alone. So we know that it works. We also know it has limitations. It has limitations in women that have dense breast tissue. It has limitations in women that are at a higher risk because of their genetics or their family history or a history of chest wall radiation or whatever it might be that put them at a higher risk. And those are the women that we really want to start adding in the ultrasounds or MRIs or contrast enhanced mammography or whatever supplemental screening tool is available by your institution. So the bottom line to this is, mammograms are the gold standards. They are the screening tool you should be getting with breast imaging. If you have findings that might put you at a higher risk, or but due to your dad's breast tissue or your family history, you need to talk to your doctor about, or your radiologist about what the best supplemental screening tool for you would be. And a lot of times it's institution specific. So my institution's very MRI heavy. So we do a lot more MRIs and screening ultrasounds. Other institutions don't have the MRIs and they do more screening ultrasound. So it's really institution specific. And I think out of all of this, the most important thing to remember is that we really are getting into the age of personalized screening. It's not a one size fits all. And actually, so many of the studies weren't even counting for race and ethnicity and things like that. So I think there's a lot of work we have to do with that. And with that being said, not every test is perfect for everyone. So it's hard to say just a one size fits all. And that's why it's so important to develop a relationship with your friendly breast radiologist or your doctor and just see what imaging screening regimen for breast cancer is best for you.
Okay. That makes a lot of sense. What's your guidance on age? So I know for me, I'm 40 is the number that we always hear, like start getting a mammogram at age 40. I was diagnosed when I was 35 years old, but I also do have a family history. So in my scenario of a family history, at what age should I have started getting a mammogram?
So, I think the question, that's a great question. And I think we're actually changing as specialists now to say what age do we get risk assessed, because it is a difference. So really we say the Society of Breast Imaging, the American College of Radiology says every woman at the age of 25 should have risk assessment. And that's something that we are not doing routinely. And it's something it should be. And that's why I'm so grateful for celebrities like Olivia Munn, who's going out and telling her story about the risk assessment that recommended the MRI that found the cancer, and her mom's cancer too, I guess. I was just reading recently. And that is because we really should be getting risk assessed by 25. So what does that mean? Well, there are a lot of risk assessment tools. There are risk assessment tools that are available online that you can get. A lot of primary cares and OBGYNs are now more and more comfortable with doing risk assessments. If you have a family history, there are usually risk assessment clinics that are associated with large institutions. We have one that's associated with our breast surgery team, and you can get in there and get your risk assessed. If your risk is high, if you're a high risk, which is over 20% due to, genetic mutations such as BRCA or CHEK2 or a family history, there are other, factors that we take into play with what was your age of your period? What was the age that you had menopause? Like these are all the factors that go into determining what your risk for breast cancer is. Then we can recommend screening at a certain age, and that age really depends on your risk.
Okay.
If you take the risk assessment out, yes, general average risk women every year starting at the age of 40 is what we recommend. I know there are conflicting recommendations out there we could talk about too, but every year starting at 40. Otherwise, 10 years before your first degree relative. So if you had a mom that was diagnosed at 39, you should start screening by 29. And that screening might not be mammography. That might be MRI with mammogram starting at 30. But that's another good rule of thumb is 10 years before the first degree relative, you should really be thinking about it. But all women should be risk assessed by 25.
Okay. That's really great. So I think for people listening in, I think one thing that I heard from what you're saying is that, maybe your GP is aware and does bring up this concept of a risk assessment, but if they don't, it's really important that you advocate for yourself and say, I would like to get one. Are you able to do it? Or do you know another doctor that can help me with this process? Because you really do have to advocate for yourself if you think that you're at a higher risk.
I couldn't agree with you more. I mean, I really think that this is all about advocating for yourself because it's really not a routine thing we're doing yet, and it should be. I think it's up to our listeners and our followers and all the women we're talking to out there every day to start spreading this word because it's so important.
Yeah, absolutely. Okay, let's get into another question. So, how come sometimes you can get a mammogram and it turns out fine, but then you end up having a lump or pain and it becomes a problem?
Yeah, this is a great question. So this is referring to what we as radiologists describe as an interval breast cancer. So an interval breast cancer is a cancer that's defined that comes in between your routine screening. So you have a normal screening mammogram and it's a couple of months after that. And then all of a sudden you're feeling something and you come back in. And actually one of the worst things that you can do is say, oh, I just had my mammogram. It was normal. It's fine. I'm just going to, it was normal. I'm sure it's fine. If you feel something new, talk to your doctor. Please talk to your doctor. And again, advocate for yourself to get, breast imaging to make sure that nothing has changed because an interval breast cancer happens, and they tend to be more aggressive because they have popped up within that short time frame since your last mammogram. So that's one scenario, is looking for the interval cancer that might have showed up. The second thing is, again, mammograms aren't perfect. And what it could have been in a place that wasn't included in your mammogram, such as very high up in the axilla or in the medial aspect of your breast on your sternum. Sometimes those areas aren't completely included in there. So that's why when you come in and you have something that you're feeling, the radiologist will do a very specialized view. They'll put a little marker on your breast where you're feeling it, and they'll do a special view that way to make sure we can really image the area you're feeling. And then, of course, which will always come back kind of in this conversation, no matter where you turn, is dense breast tissue. So some things are just hiding within dense breast tissue, and that is just a limitation of mammography. So those are kind of some of the reasons that might happen. But I think the most important take home point, again, is if you're feeling something, don't ignore it. Talk to your doctor about it to see if you need to come for breast imaging.
Okay, that makes a lot of sense. Yeah. So if it's something like I think the takeaway here is that even if you just had a mammogram and you feel something new, that you should still take that seriously and don't just rely on your previous mammogram.
Yes. And there are special views that we need to do that weren't included in your screening mammogram if you're feeling something new.
Okay, perfect. This question came up quite a bit and it's related to two different questions, but do mammograms end up causing more harm than good? And do you think a routine mammogram could eventually lead to a breast cancer diagnosis? Like, is the screening mechanism itself like something that causes cancer in the long term?
Yes. So that's a good question. It comes up a lot. And I think it's really important for us to kind of stop and think about breast imaging because there is so much misinformation out there. There's a lot of health anxiety about the radiation that mammograms give. There's just a lot of misinformation out there. And I think it's a really good moment for us to stop and talk about it. The radiation from mammograms is extremely low. It's lower than the FDA approved dose. It is equivalent to walking around in your world for a few weeks. So most people don't realize that when we're walking around outside, there is a low amount of radiation that's just in our environment. It's called background radiation. And that's just normal. It's normal radiation that's there. And we do get radiation from mammograms and other imaging, but it's so low and negligible. And the benefits of mammography and early diagnosis, which the key to early diagnosis is catching things before you can feel it, before it spreads to your lymph nodes, it far outweighs any risk from radiation. So again, the radiation dose from mammography is equivalent to a few weeks of walking around in your world. It's actually equivalent to a transcontinental flight. So that's how low it is. We do that without thinking, right? And so to not get a mammogram because of the radiation risk is not a reason to get it. And I think again, talking about celebrities, Ananda Lewis went on and talked about this, on her social media. And she said, I was scared of mammograms because of radiation for so many years. And she urged women to not take that path and to get the mammograms. The reason is because mammograms are the only thing that shows breast cancer with calcifications. So breast cancer coming as calcifications or presenting as calcifications, mammography is the only thing that can really detect that. You can't see calcifications well on MRI or ultrasound. And that's why people will come in and say, my breasts are dense. I don't need a mammogram. I should get an ultrasound. But we miss that earliest form of breast cancer, which are calcifications. So that's why that's so important. The second risk of mammography, so one is that people worry about is the radiation. The second thing are false positives and anxiety. And that's actually why, if you look at the US Preventative Task Force, they recommend starting at 40 every 2 years, whereas Society of Breast Imaging says starting at 40 every year. And the reason they cite for starting at 40 every 2 years is because of the risk of anxiety that it brings patients because of false positives. And I really think that's just really an education and a conversation, right? So again, imaging, we might find things that are not cancer that may have you come back that we have to ultrasound. It might lead to biopsies that are not cancerous. And that risk of a false positive can lead to a lot of anxiety in patients. But I think for that, it's just a conversation about it. It's very common to get a biopsy, and we want to make sure that we're evaluating things so we can make sure we're not missing anything.
Okay, so let's maybe talk a little bit about MRIs. So you talked about mammograms. Are MRIs more accurate than a mammogram, or are they looking at something different than a mammogram wouldn't pick up?
Yeah. I always say MRIs and ultrasound work with mammograms, not in lieu of. So MRIs, and it's hard, accuracy is very hard actually in breast imaging to talk about because there's so many confounding variables. So accuracy can change with breast density, it can change with family, with age, it can change with ethnicity. So it's really hard to use the word accuracy because there's so many confounding variables. But what we use in breast imaging is sensitivity. So how sensitive is a tool in picking up a breast cancer? So MRI is the most sensitive exam that we have. So it picks up a lot of things. So what MRI is looking for is you get gadolinium contrast, and it's looking for areas that have vascularity. So breast cancer is vascular, so it will take up contrast. But the problem is a lot of normal things take up contrast too. So normal background tissue takes up contrast. A fibroadenoma, which is a benign mass, takes up contrast. Little normal ditzels or other masses in your breast can take up contrast. So that's the issue with MRI. It's so sensitive that it's going to catch a lot of things, but it's going to catch a lot of things that are also benign. And so that's why it is the most sensitive, more sensitive than mammography, but it's also less specific. So it catches a lot of things and we're not sure what it is. So again, it works together with mammography. It's an amazing adjuvant tool. It's an amazing screening tool, especially for women with dense breast tissue, extremely dense breast tissue and high risk. But it does have a higher false positive rate.
Okay. And how does the radiation compare in an MRI to a mammogram?
Great question. So there's actually no radiation in MRI and no radiation in ultrasound. So MRI uses electromagnetic waves and ultrasound uses sound waves. So neither one of those actually uses radiation.
Okay. So for someone who is like very much like anti-radiation, if they can't get on board with getting a mammogram, do you think doing an MRI or ultrasound is at least better than not doing anything?
Yeah, so that's what I always say, right? So I usually talk to patients and try and understand why they're nervous about mammography. But at the end of the day, of course, we're talking about you can be your own advocate. You get to decide what you want to do, right? Which is amazing. It's so amazing to be in this place in medicine. There's so much information, and you as a patient can be your own advocate. So if a patient really says, you know what, I hear you, I understand what you're saying, I still don't want the mammogram. Of course, any screening is better than no screening, but we have to know that without the mammogram and without being able to find those small little calcifications, we are limited in what we can find.
Okay. Got it. Will you explain what calcifications are?
Yeah. So calcifications are very tiny specks of calcium in our breast. So they almost look like grains of sand. And if you look at a mammogram, they really actually not even almost, they really do look like grains of sand on a mammogram. We form calcifications all over our body, right? So kidney stones, those are calcified stones in our kidney. Gallstones in our bone have calcium. Calcifications on our mammogram are not related to the amount of calcium you take in. Sometimes people will say, oh, I took a lot of calcium and that's why I have calcifications. That's not it. These are micro calcifications, tiny, tiny, tiny little grains of sand that form in our breast. Why do they matter? Well, the majority of calcifications are benign. So they're due to, people that breastfed, maybe they can form calcifications or have trauma to your breast. Surgery, breast surgery can form calcifications. Cysts form calcifications. So there are a lot of benign reasons. Fibroadenomas, these benign masses we talked about, can form calcifications. But calcifications can also be the very earliest sign of breast cancer. And so when we see new calcifications that pop up, calcifications that look we call them pleomorphic, which is our word for saying all different shapes and sizes, or calcifications are a little bit fuzzier. They're very specific morphology of calcifications we're looking for. We recommend a biopsy of those to make sure they're not the earliest breast cancer that could be forming, which is DCIS.
Got it. Okay. That's really helpful. Thank you. Okay. So we've got a question here that says, do full body MRIs like a pre-novo negate the need for a separate mammogram?
I'm so glad someone asked this question. So, these whole body scans are really controversial. There are a lot of pros and cons to them, right? And one of the things I find scariest is they give people a sense of reassurance. And so I've seen patients that have delayed their mammograms because they say, oh, I had a whole body scan and it was normal. And so I felt like I didn't need to get my mammogram. And I'll be honest, as a radiologist, I have not gotten a whole body scan. And there are reasons why I haven't. And I think, one of the things we have to realize, again, we keep kind of coming back to the same theme, is no imaging is perfect, right? So these scans don't use contrast. And so they are limited in what we can find. We just talked about breast MRI. We need contrast to be able to detect breast cancer with MRI. We cannot detect breast cancer without contrast. So you really are not evaluating your breast for breast cancer with these whole body scans. I think people feel reassured because sometimes they'll comment on your breast. So they'll say, oh, there's cysts in your breast. So people will say, oh, I feel like they saw cysts. They looked at my breast. But you really, cysts are bags of water. And so you can see bags of water without contrast, but you cannot see the findings that are cancerous that are taking up contrast. They're not going to show up without contrast. So you absolutely still need your mammograms. And the same goes for all surveillance screening tools. So colonoscopies, you still need your colonoscopy. You still need your pap smears. So I think really, really important to remember. So there are always things and there's stories you're going to hear with whole body scans catching an early cancer. But we see that with all imaging. We call that in imaging, and as a radiologist, we call that an incidental loma. So someone comes in because they had a car accident and gets a CT scan, and we find an incidental kidney cancer, right? So that happens. And we know that the more we scan, the more we're going to find. But I think the two things we just got to remember with these whole body scans is if you get them, and I'm not recommending for or against them, we just don't have enough information. They're not the long-term trials to tell us what this does for, morbidity and mortality in the future. So, until we have those studies, we really can't recommend for or against them. But if you are getting them, just remember, don't be reassured by it and not get your routine surveillance. You still have to get that. But the other thing is it can actually lead to more health anxiety because we can find things that lead to extra workup. So, I had someone the other day that went for one and they found a liver mass. And it ended up being a hemangioma, which is a normal liver mass that people can form. But we can see that with non-contrast. And so that led to a liver MRI and more studies. And so, you just have to realize that whenever you scan, it might lead to more scans that might be benign. And that, again, is one of those false positives that we talked about, even with breast imaging.
Got it. So you mentioned contrast. Is it gadolinium? Is that the name of the contrast?
Yes.
So someone actually asked, like, is gadolinium harmful, and can you do the imaging without it? But you're saying that it's not as accurate because it's not going to uptake as much.
Yeah, but actually we can't screen for breast cancer without it. And so we really need the gadolinium. And I think it's a great question. So gadolinium was introduced 30 to 40 years ago, and it really changed imaging because now you have an MRI scanner and you add that contrast and you can really just see so much more definition of the body and pathology. There are a few, concerns about gadolinium that are in the literature. So it's a good time to talk about them if you're okay with that, if that was the question. So of course, anytime you add contrast, there's always a chance of an allergy. So the same with contrast that you get with a CT scan, which is a different type of contrast, there's always a chance of a contrast allergy. Gadolinium contrast allergies are actually lower than the iodinated contrast we get with the CAT scan, so lower risk of it. And that risk is still very, very low. It's very, very low. The second thing we see nephrogenic systemic fibrosis, or NSF, which is kind of fibrotic tissue that can form in your skin and organs. And this is seen in patients that have that are in kidney failure that get gadolinium. So we really try to make sure that we're checking all these labs before we get the contrast and trying to avoid it in patients that might have kidney failure. We've also actually changed the class of gadolinium that we're using, and that class is much more safe and against NSF. So actually that risk of NSF has significantly decreased as well. And again, in people that have normal kidneys, it's a negligible risk. And the third that people are really worried about that we hear more and more as it comes into the news are there could be trace amounts of gadolinium deposits in your body, so in your brain and in your body. And although that does happen, there are multiple large trials that have showed that there's no biological or clinical adverse events from that. So it could happen, but there's nothing, it doesn't have an adverse effect because of it. And again, the benefits of screening MRIs, particularly in patients that are high risk or dense breast tissue, that risk is low compared to the benefit that we gain from finding cancers at an early stage.
Got it. And so one other question that we've got quite a bit is, like, how safe, like, frequency wise, are these to do? You mentioned, like, it's the same as taking a continental or transcontinental flight. You don't think there's any issue with doing this on a yearly basis or even every 6-month basis?
Absolutely. The risk is really negligible. Even in patients, sometimes we find things like calcifications we were just talking about that we want to follow every 6 months. And that makes patients nervous because they're like, oh my gosh, I was already worried about, a mammogram every year. And now you're telling me every 6 months. We usually do it every 6 months for a total of 2 years. But even that is very, very safe.
Okay. Got it. So I have a BRCA2 mutation. And when I got diagnosed, my brother and sister both ended up getting their genetic testing. And it turns out that we all have the BRCA2 mutation, which is wild. But I know for my sister, she's, I think, 44, 45 years old. And the imaging that they're recommending for her is every 6 months alternating a mammogram and an MRI. Is that kind of the standard if you have a genetic mutation?
Yeah, it really is the standard for any time that we're adding an MRI into your supplemental screening. And the reason for that is kind of going back to our beginning of our conversation with the interval cancer. So making sure that if something's going to pop up in that year, that we're catching it as early as we can. And then we also talked about MRI and mammograms working together, not in lieu of each other. So it's nice because the MRI can pick up things that the mammogram might not have seen. So, and I always tell my patients, you're never going a full year without any sort of screening, particularly for high risk patients or patients that have this in their family and it's just kind of their world. It is really hard to go for a full year without some sort of screening, right? You're always thinking about it. So I think it's really nice also to have that interval scan to make sure nothing has popped up. In patients that, again, some screenings better than no screening. So some patients are like, oh my gosh, I can barely even keep up with a mammogram a year. There's no way I can do 2 scans a year for breast. And those patients, I say, that's fine. Just get it at the same time as your mammogram, as long as you're getting it. Right. So, and that actually helps when you get it at the same time of your mammogram. So it can help with recall rates. If we see something on the mammogram that looks funny, but they just had an MRI, it may make us feel like, oh, this just looks like tissue. And that kind of helps with our false positivity with mammograms anyways. But yes, the standard is really, if you can do it and commit to it, 6 months.
6 months. Okay. Okay, perfect. This question was really good. This next one. So it's where or how to get a second opinion for a breast MRI. Like, is there some online service or somewhere that you can reach out to radiologists to get a second opinion on something?
Yeah, it's a great question. There really isn't a standardized way of doing that right now. The way it's really institution specific. So for us, we do review outside imaging, but the way we do it is they have to come in. It's patients that have gotten their imaging or their diagnosis outside, and they're coming in and establishing care with a breast surgeon or an oncologist. So even patients that don't have a diagnosis of breast cancer, if they're coming into our high risk clinic and they're bringing their outside films, then we will reread that. And there's a whole outside read process for that. It's pretty complicated because we really can't just read an MRI by itself. You really have to read an MRI with previous MRIs, with the mammograms, with the full story, knowing the history. And so because of that, there's a whole process, an outside read process that most institutions have. So my best advice would be to talk to your doctor about where they would recommend you getting a second opinion for. And if you're doing an MRI second opinion because of a diagnosis of breast cancer, find a place with you want to see their surgeon, second opinion with the surgeon, and they'll have an outside read process. And if it's for high risk, find where your high risk clinic is and see what their process is.
Okay. And is it typical? So let's say that you went to one center, got your MRI, and then you want to go to like a cancer specific center. Is it most likely that they would scan again and have their own radiologist look at the films?
Again, it's really institution specific. So for us, we try not to have the patient have to redo the whole MRI because they've already paid for it. So if the problem is also is that different institutions have different scanner protocols, et cetera. So if the MRI scan that comes in from the outside is similar to our protocol and we feel like the technical part of the MRI is up to our standards, then we will read it as an outside read. If there's any question, if there's motion, if the contrast isn't perfect, et cetera, then we will repeat it just so that the patient gets the best scan possible because we want to recommend based on the best imaging. But that's our institutions. Some places do actually have you repeat the whole scan.
Okay, got it. And then the last question related to MRIs, it's not related to breasts, but it's related to liver. Is it true that with an MRI, you can't see if the liver is fatty and that you need another type of scan to tell that part?
Yeah, so fatty liver is the most common liver disease worldwide. It's also known as non-alcoholic fatty liver. So it's in patients that it's not due to drinking. It's in patients that oftentimes don't drink at all. And it's kind of fat infiltration into the liver that can can lead to fibrosis and can lead to cirrhosis eventually. For just bringing it back to breast, we do catch part of the liver on a breast MRI, but the breast MRI is really protocoled for the breast. So it's not doing a great job looking at the liver. Sometimes we can catch something like we talked about, the benign hemangioma that ends up leading to other tests, but we really can't evaluate the liver for liver disease. So for liver disease, usually, again, you want to talk to your doctor. The body radiologists are the people who read that. I actually don't read any body anymore. I only read breast, but they do have specialized liver protocols that they can look at. They have specialized liver protocols that can measure the amount of fat in the liver. They have special liver protocols that can measure how elastic your liver is or how fibrotic it is. And so they use those tools to determine the degree of fatty liver that you have.
Okay, perfect. You mentioned a few times dense breasts. We got a couple of questions around that. So I know that there was like FDA guidelines that recently came up that said that now that if you do have breast dense, you have to notify the patient that their breasts are dense. But what does someone need to do if they have dense breast tissue? Like, they're probably worried that they could miss something. So is there additional screening that they need to do?
Yeah, I think maybe let's start by talking about what dense breast tissue is, because I feel like dense breast tissue is something that everyone's so scared about. I mean, it literally comes up at dinner conversations with my girlfriends all the time now. We're talking about the weather, and then everyone's like, what is dense breast tissue? I have dense breast. So let's talk about dense breast. So every breast radiologist has their own analogy that they use. I use a polar bear in a snowstorm. So imagine a polar bear standing in a snowstorm, really hard to see that polar bear. The polar bear is white, that snowstorm is white. You're not going to be able to see that. As the snowstorm gets thicker, that polar bear is going to be really hard to see. If you have a polar bear standing in grass, really easy to see. That polar bear is going to stand out. So the grass is tissue that's not dense. The snowstorm is tissue that's dense. So what we're looking at on mammograms are white masses or white calcifications in a sea of white tissue. It can sometimes be very hard to see. So again, it doesn't mean that you shouldn't get your mammograms, because we can see some masses, we can see calcifications. With the introduction of 3D mammography or tomosynthesis, which is basically, it is a little bit more radiation, but it basically is taking slices through your breast so we can see through the breast tissue. It helps us see through that tissue even more. And so it really helps us with mammography and dense breast tissue. But if you get that letter, and you're right, you'll get the letter that says you have dense breast, your report will say your breast tissue is dense, which limits mammography. If you get that, then that's the kind of the key for you to talk to your doctor about what supplemental screening tools are available at your institution. So again, for me, people that have extremely dense breast tissue, we actually recommend the MRI because it can really see breast tissue really well. And then for people that might have just heterogeneously dense breast tissue, we do ultrasounds. Some institutions that we're not doing do contrast enhanced mammography. So they do contrast with mammograms to help see through that. So which supplemental screening tool you get is really dependent on what is available or where you go get your breast imaging. But you probably should get some sort of supplemental tool if you have breast imaging. The only thing you have to do is get your mammogram. I always say everything else is extra credit.
Okay, wonderful. So I guess one last question is, what's kind of the difference between an MRI and a PET scan? Like, when would you want to do a PET scan for something that's come up in the breast?
Yeah, it's a good question. So we talked about MRI a little bit already. Let's talk about a PET scan. So a PET scan uses a molecule, usually a sugar molecule. So we call that FDG, which you probably have heard a lot. So FDG, and that FDG is attached to a radio tracer, and then it's injected into your body. And so basically the FDG, because it's a sugar molecule, it's going to go to places in your body that have high metabolic rates. So if you have inflammation, so you have an injury in your thigh, that your body's working really hard there with that inflammation to cure that or to help solve that or make it that better. So they're going to have a high metabolic rate of repair there. And so that FDG is going to be attracted to your thigh. Areas that have cancer, high metabolic rate. So that FDG is going to go and localize that area. So the PET scan helps us really evaluate and look at places that have high areas of metabolic rate, which are usually inflammation or cancer cells. PET scans are really good for following and seeing surveillance of disease. So it's used for surveillance of people with metastatic breast cancer to see where is it, how is it. It's giving you a whole overview of your body. It can be used in some brain diseases. It can be used in heart diseases. But the sensitivity is not high enough to be used as a screening tool for breast cancer. It's good for a surveillance tool.
Okay, that makes sense. I want to share a story, like my personal story, and just not to scare people, but also just for awareness. And I'd love to get your take on it as well. So, 2 months ago, I had a mammogram and ultrasound done, and they said that the primary tumor in my breast was gone. They had placed clips in there, and they were saying that, we see the clips, but there's no tumor around it anymore. I proceeded with getting a double mastectomy, and in the mastectomy, they took samples and sent it off for biopsy, and it came back that there was cancer in the breast. So I wanted to just get your take on, I don't think it's an imaging miss, but is it just the fact that those are the limits of imaging, that we don't always pick up everything?
Yeah. Yeah, I mean, this is thank you for sharing your story. I think it's really important to talk about these things. So this is what we talk about as being a false negative in imaging, right? So the imaging is negative, but there's something there. So, it can happen for many reasons in people that don't have a breast cancer diagnosis, like we talked about, things hiding, not included, et cetera, on your mammogram. Specifically in these situations, what we're looking at when people have breast cancer and are going through neoadjuvant chemotherapy or therapy before surgery, and just, for the listeners, that's talking about therapies that we do before surgery to shrink the tumor size before you go to surgery. So, you get your diagnosis and people think, and I'm sure you can share about this, that, okay, I have this diagnosis, let's go to surgery. We're ready to go to surgery. Let's get it out. But really, a lot of times it's doing those therapies for months until we actually go to surgery. And so then what we're looking for on our imaging is, what is the radiological response? So we're looking for radiological complete response. And what that means is, imaging complete response is that there's nothing there on the imaging. And so what does that look like? That looks like on the mammogram, there could have been a mass that we no longer can detect. What that can look like on ultrasound, the same thing. We saw a mass before, now we can no longer see it with imaging. And with MRI, we talked about giving contrast for MRI, and the MRI, the tumor taking up, because it's so vascular, taking up the contrast. Well, when we give these neoadjuvant chemotherapies, the point about a lot of these is to decrease the vascularity of the tumor. So it's no longer vascular enough to take up the contrast. So it can look like there's nothing there. But the gold standard of all of this, when we talk about what is left after chemotherapy or any sort of therapy, the gold standard is the pathologic complete response. So you can have imaging complete response and not have pathologic complete response. And that's why it's so important to get that final pathologic diagnosis to see what's there.
Yeah. I also know that I hear that a lot of people are nervous about getting a biopsy. There's like this myth that's, that a biopsy, like sticking a needle in it, would spread the cancer further. What are your thoughts on that?
Yeah, I mean, every time, not every time, but I would say a lot of times I'm consenting, this question comes up. And I think there is, again, misinformation about this out there. Our biopsies that we do as radiologists are core needle biopsies. So we're taking a very small sample from an area that we're looking at. And the biopsies are really designed to not disrupt the surrounding tissue in a large way, so that they're very, very safe. And so when we're asking about that, what that's referring to is something called seeding the track, which means when we are biopsying, we're actually seeding the track with little cancer cells as we do the biopsy. But to date, there's no clinical trials or studies that show that that changes the risk of spreading metastatic disease or the risk of recurrence or anything like that. So the risk of seeding the track is really negligible. And again, it's a risk benefit. The benefit of the diagnosis and early detection with that biopsy far outweighs any risks.
Okay. That's great. And then, so I know there's core biopsies and there's also, is it fine needle biopsies?
Yeah.
What's the difference, and when would you use one versus the other?
The difference is with the needle size. So a final needle biopsy uses a very, very tiny needle, whereas a core biopsy uses a little bit bigger needle. And I actually, in my practice, we don't use fine needle biopsies at all. So anytime we take a sample, we actually take a core through it and send it off to pathology, because the samples are so, so small in fine needle. We use fine needle biopsies in other places in the body, like a thyroid biopsy when you're in a very small space. But for breast imaging, and again, this is institution specific and practice specific also, our radiologists and our pathologists like the tissue sample that we get from a core needle biopsy, because for me, if I'm going to take a sample, the risks are similar. I would rather, get a sample that really can get the most information.
Yeah, that makes a lot of sense. Okay, perfect. I think that's all the questions that we had, Dr. Bole. I really enjoyed our conversation. And hopefully, for people listening in, you feel a little bit more empowered and, more in control about what your options are for testing. And definitely just a reminder to everyone that, while getting a mammogram can feel scary, it's your biggest shot at having early detection. And so definitely don't shy away from doing those.
Absolutely. And you know what? If I'm going to be really honest, and admittedly, I get scared before a mammogram, and I'm a breast radiologist. So it's really normal. And we just need to normalize that. No one likes getting them, but we're all getting them together. And I think your words are so, so powerful about being your own advocate. You have to be your own advocate. And I just really appreciate you sharing your story so we can help share this information with patients out there.
Absolutely. Dr. Bole, how can people find you and connect with you?
You can email me at youradoctorright@gmail.com. You can listen to my podcast, which is also called You're a Doctor Right. And it's also my Instagram handle. So you feel free to comment, DM me. Anyway, I'm always happy to get any questions.
Perfect. Thank you so much for being here.
Of course. Thank you.
Thanks for listening to The Other C Word, hosted by Bismilology. New episodes drop Mondays. Connect with me on socials at Bismilology, and let's all learn, grow, and inspire each other.